Phototherapy is a popular treatment for psoriasis, but many wonder how it stacks up against biologics, a more commonly discussed option. Today, my aim is to break down the nuances that make phototherapy an essential part of dermatology care. I'm joined with Dr. Joel Gelfand, the director of the Center for Clinical Sciences in Dermatology and Psoriasis and Phototherapy Treatment Center at the University of Pennsylvania Perelman School of Medicine. Dr. Gelfand has made significant contributions to our understanding of the effectiveness of phototherapy for people with psoriasis. Dr. Gelfand, this should be a very interesting conversation. Welcome. I'm glad you're joining us today so we can talk about phototherapy.
Hannah, it's great to finally be on your podcast.
So first, let's start off by understanding phototherapy's mechanism. Could you explain to our audience what the mechanism by which phototherapy works in treating psoriasis and what changes occur at the cellular level that lead to improvement in symptoms?
You know, I think this is a great question, and it remains very actively investigated. There's still scientists around the world who are looking at the new ways that we understand how phototherapy works to modulate the immune response in the skin. And what's interesting when you look at this effects on psoriasis is it hits the same pathways that we use when we're using biologics. It tends to lower things like cytokines like IL-17, TNF, things we know are so important to driving psoriatic disease. It also had some other cytokines too, including interleukin-6, which is an important cytokine for cardiovascular risk. It lowers that both in the skin but also in the blood, and that finding seems to suggest that potentially phototherapy could help for cardiovascular outcomes, preventing them. And a key thing that we think that ultraviolet phototherapy does is sort of decrease the activity of antigen-presenting cells. And so psoriasis is a disease, essentially an immunologic disease, where these dendritic cells are presenting protein that is really self-protein to T cells, and the T cells are reacting to that. And by knocking out the dendritic cells with ultraviolet B, that tends to be inducing remissions in patients. So, if you use phototherapy on a regular basis, we all have patients, some of whom do incredibly well, and then they're clear for months or years. It's likely that effect is driven by interrupting the interaction of antigen presentation and the adaptive immune response of T cells.
So you mentioned cardiovascular. Do you believe that anyone who has psoriasis and a cardiovascular risk factor automatically should be getting phototherapy?
Well, I think that the state of our knowledge right now is that we just don't know for certain if successful treatment of psoriasis will lower the risk of cardiovascular events. And so I think it's a multi-pronged approach. One is we certainly should control skin inflammation. That improves the patient's well-being, their health-related quality of life, and helps them live a better life overall. We certainly know that as dermatologists. But then holistically, we need to address other cardiovascular risk factors that commingle so commonly in the psoriatic disease population. They tend to be insulin resistance, have a higher rate of diabetes and dyslipidemias, tend to be hypertensive and overweight. They tend to smoke more. So all of those factors need to be addressed for the patient, either by us screening for cardiovascular risk factors and referring back to their primary care doctor, or asking them to go to their primary care doctor, being aware to the fact that having psoriasis portends higher cardiovascular risk. Of course, exercising more regularly, being more physically active, having a healthy diet, that is part of the equation as well. So I think the way to think about it as a dermatologist is, one, we need to clear the skin. Two, we need to encourage the patient to live a healthier lifestyle, quit smoking, exercise regularly, have a healthy diet. And then three, we should check their blood pressure, screen them for diabetes with a hemoglobin A1C. It's easy to do. Check their cholesterol. And if these things are abnormal, we should let them know, see a primary doctor, and you need to have these things addressed to lower future risk of heart disease.
I also wonder if the risk of mental illness or depression goes down if people are forced to come into the office for phototherapy, because it forces them to leave their house and get dressed and have a routine and get off the couch.
That's a really interesting insight, Hannah. And it is an intersection between, medical science and clinical care, right? And one of my favorite quotes by a person from Harvard Medical School was that the secret of caring for the patient is caring for the patient. And phototherapy is a very unique way of caring for patients because they're seeing our staff on a regular basis, our staff who care about patients, who can relate to the patient, empathize with them. And in some of our trials, when we were looking at cardiovascular effects of treatments, we randomized people to get either phototherapy, a TNF inhibitor called adalimumab, or placebo. And what was striking is that the patients randomized to phototherapy did better on a lot of health-related quality of life measures than those on adalimumab, including pain. Like we all know TNF inhibitors are very good with arthritis and reducing pain. People on phototherapy had a bigger reduction in pain, symptoms of pain, than people getting adalimumab, which is kind of surprising finding. Some of it may be a direct response from the treatment, but some of it may be the fact that, when you're seeing a healthcare provider and our staff on a regular basis, it may improve the patient's overall outlook as well.
Yeah, and that, over time, I could imagine it becomes almost like a family because you're seeing the patients on such a continuous basis that you're just so familiar with them. So they feel like a comfort coming into the office.
I think what's really great about phototherapy is that it's sort of a throwback to the way we used to take care of patients. We really took care of people, as opposed to just putting orders in an electronic medical record and having things sent to them, and we don't see them again for a year or interact in any way, shape, or form. And there's certainly some value, I think, in this patient contact they get with our staff.
Most definitely. So I know that biologics have become very popular in the most recent years, and there's almost like a quickness to prescribe them. Do you take a different approach in your practice when you're seeing a patient who is a good candidate for phototherapy, and do you say, Mr. Jones, you would be great with phototherapy, and if we don't get you to where we want you to be with your skin, then we'll maybe consider adding on a biologic? Or do you immediately say, no, you need both biologic and phototherapy? What's your approach?
Yeah, so I'm a strong believer in shared decision making and empowering our patients with this lifelong chronic disease with the information they need to make treatment decisions that fit their values and their individual preferences and personal situation. And I really want to encourage my colleagues to take this approach, because the issue is when a patient with psoriasis enters our office, they've often been living with disease for years. They have strong opinions based on their lived experience with the disease. If we are too quick to pigeonhole them in a treatment option that doesn't work for them, they will often politely say, "Thank you, doctor," and then they don't follow up with us again. And
Thank you and goodbye.
Right, exactly, right. So usually what I'll do is, based on my understanding of the patient, objectively understanding their disease activity and severity, and their underlying health issues, I'll explain, what's reasonable. So, for example, a patient who has predominantly scalp, nail, and genital disease, that's not a good candidate for phototherapy, right? Light therapy is not going to hit those areas. But if it's predominantly trunk and extremities, then we'll discuss, okay, these are your options. One is ultraviolet phototherapy, one is pills by mouth, another one is injectable medications, right? And we all know we have patients out there who they don't want to be on medications. They'd rather use things that they consider to be natural. And what's more natural than ultraviolet light? Basically nothing, right? And so that gives us the full armamentarium to help patients get better, get control of their disease. Now, more broadly, I'll say there's other reasons why we should be thinking about phototherapy. One key issue is that the cost of biologics are astronomical. We spent in the United States in 2023 over $27 billion on pharmaceutical management of psoriasis. It's astonishing. And one out of every three healthcare dollars used to manage inflammatory diseases, autoimmune diseases, went to psoriasis in 2023. Wow. It's a recent paper in Nature Reviews Biotechnology. And that's not sustainable when it comes down to it. And in many systems like, say, Kaiser Permanente, where they're not only the provider but also the insurer, they just make phototherapy available to people either in the office or at home without copays or barriers. And they've found that that's been a very patient-centered way of managing costs, because many of their patients are happy to do phototherapy at home or come into the office if they're able to do it. And that lowers the number of people who then have to go on very expensive oral medications or injectable biologics. The other thing that we found in our research is that despite all the advances in psoriasis management, a lot of patients do well and then lose response and constantly cycling from one biologic to another. And here, phototherapy can be very valuable in helping, help people cross the finish line, so to speak. That they're on a biologic, they're doing well, but not great. Maybe they have a little bit of a mini flare and they're having strep or an infection or something like that. A course of phototherapy can also often help clean things up for patients, and therefore avoid this cycle we get into where we just keep cycling through biologics, right? And cycling is very expensive in the healthcare system also, because it involves higher doses of biologics as part of the induction period, and there's difficulties in terms of organizing these shifts in the healthcare system. In our recent study that I presented at the American Academy of Dermatology weight-breaking research session, we did a pragmatic study, meaning that was embedded in routine patient care at 42 sites, 42 dermatology practices in the United States. We found that 12% of patients were currently taking a pill or a biologic at a time that the dermatologist, recommended them to go on phototherapy in addition to what they were on systemically. And about 40% of people previously have been on oral medication or a biologic. And so this is a reminder that, we've made a lot of progress, but for a lifelong disease, that when people start losing response over time, we need a lot of ways of solving this problem. We can't just say, this is the one tool I'm going to use in my toolbox. We need a lot of different tools to solve this issue for our patients.
So what do you think the downsides of phototherapy are?
Well, the clear downsides really are indirect and direct cost to patients and inconvenience to patients. Those are the biggest downsides. Because in our mixed-up healthcare system, I could prescribe a biologic that may cost a payer $60,000 a year, but the patient will pay nothing for it, right? They could get a coupon or something like that, and their copay is absolved. Whereas they want to do phototherapy in the office, they may have to pay a copay of, in the White study, the average copay was $20 patients have to pay per treatment. It's 2 or 3 treatments a week for roughly 10 to 12 weeks. It ends up being about $600 a patient. So that could be a real burden for patients, not to mention time off from work, for example. So we found in the White study, on average, patients spent about 50 minutes, nearly an hour, traveling to and from phototherapy. I used to only have patients in my own practice who are clinicians in the health system. They work 2 floors away from phototherapy, and they can't find 5 minutes to go down and get treated, right? This is the nature of the busy world we're in. I think that's why we did the White study, to see if we could offer phototherapy at home to patients and get the same results. And that's basically was the main conclusion of the White study, was that when we randomized people to get treatment at home, we used what's called a Davalin 7 series with a dosimeter. They basically got the same, or if not better, outcomes than they got in the office with phototherapy. And we hope this data will shift practice, one, to help clinicians feel more comfortable prescribing home phototherapy, because it's a very diverse patient population. In fact, people of color did the best on home phototherapy relative to the office, because home treatment really is more easy to adhere to and the dosing was more consistent. And we're hoping also payers will pay attention to this data and make home treatment more available, because a home machine costs about $4,000 to $5,000 as a one-time cost to an insurer, compared to biologics, which is an annual cost of tens of thousands of dollars. It's relatively inexpensive for a payer to make this available. And we know Medicare Part B covers home phototherapy, but many private insurers previously have not covered it because of uncertainty around how well it would work in the U.S. population. And we're hoping these White data that we've released to AAD and will soon publish will really shift things so providers can easily prescribe it and patients can easily get access to it when they need it.
It sounds like the compliance is actually really great. And I would imagine for even the underserved population who, they can't miss a day of work, if they can come home and do their light therapy at home, that's just a huge benefit.
Exactly right. And the other thing our patients tell us is that, listen, any patient with chronic disease, what they're afraid of is not being able to have control of it, and the loss of control over their bodies and their well-being. And, what they need to know is my treatment's here if I need it. So when they have a machine in their house, that gives a lot of comfort. They can clear their skin when they need it, If it's coming back, they go back on treatment, and that's a pretty helpful alternative. The other thing, of course, we should discuss is that phototherapy is ultraviolet radiation. So as dermatologists, we always worry about risk of skin cancer related to ultraviolet B phototherapy. It's interesting here that the recent studies that have come out in this topic, including one from Canada, where it's primarily fair-skinned patients, haven't really shown any evidence of a higher risk of skin cancer, basal cell or squamous cell, or melanoma, with narrowband phototherapy compared to the general population risk. It's kind of striking finding, a little counterintuitive, or not what we would have thought. I think the way I tell patients about this is that we certainly worry about this as dermatologists for fair-skinned patients in particular, and we worry about premature aging of the skin as well. So patients need to be aware of that. Clinically speaking, no, it doesn't seem to be a major problem. It's not like my patients have done phototherapy for years show up with many skin cancers in clinical practice the way we would see with PUVA. When we used PUVA many years ago, those patients would come in with dozens and dozens of skin cancers, very hard to manage. That's not what we see with people on narrowband phototherapy for a long period of time.
I wonder if that has to do with the fact that maybe those fair-skinned individuals are more cautious in the sun, so they wouldn't be the type that would get, obviously their skin type is more prone to skin cancer, but they're more cautious about being exposed to the high intensity of the sun.
There's certainly some of that, and of course when we're using narrowband phototherapy, you're really using essentially one wavelength of light, 311. That's less carcinogenic than the other wavelengths of light that are in sunlight, and there's very limited UVA in there, and UVA causes a lot of sun damage and other skin cancers as well. So it's likely that the technological advance in narrowband phototherapy is likely just less carcinogenic in humans compared to just natural sunlight.
So once they finish their 10 to 12 week course of phototherapy, how often do you find that you have to repeat this course? I always talk about our patients always ask, am I going to be on this biologic for the rest of my life? Mm-hmm. Is this a lifelong treatment? So I just want to know how you perceive phototherapy, how often you have to repeat this cycle.
Yeah, so as I always tell my patients, we don't have a cure for psoriasis. Any treatment we use, even if it's going to be intermittent treatment, we have to expect eventually we'll have to come back to using it again. And so in the case of phototherapy, when patients have a very good response, most patients can retain that response for 6 months to a year or so. Patients will often know pretty well where things are going. So they'll see, I'm still getting spots here while I'm on treatment, or I'm not getting anything new, right? And that gives you a sense of where things are headed. The other thing, the advances in new topical medications, that's giving us better ways of maintaining clearance, right? So someone may come in with, say, 10% of their body covered with psoriasis. That's really hard to manage topically. But they get clear with phototherapy or maybe one of our pills or a biologic, and if they stop phototherapy or the systemic therapy, when things start to come back, they can then hit it with, say, tapinarof or roflumilast or just more traditional topical treatments and get control of it before it gets too active again. So, the challenge we have, though, as dermatologists is that we still don't know who is going to have long-term clearance and doesn't need continuous treatments or repeated treatments, and who needs chronic long-term maintenance therapy, right? So we're often stuck with biologics, people are on for a long time, even though they may not need it. I think with phototherapy, the way I think about it as a clinician is that if a patient needs 1 or 2 courses of phototherapy a year to manage their disease, that's pretty good, and I think that's totally reasonable, okay? But I think if patients need to do phototherapy, month in and month out, multiple courses a year, I would feel like, that's probably not the best strategy for the patient, and I would really encourage that patient, if they were reluctant to be on biologics or pills, to say, what, this is a lot of treatment you're doing to manage this. We should do something that's a little bit simpler if you're not having, what we assume to be a very good response.
So you would say the average recurrence rate after finishing your first course of phototherapy is about 6 months?
Roughly about 6 months is when people start having significant recurrence or disease where they may need another course. But again, it's highly variable from patient to patient. Some patients have very prolonged remissions that last for years. Others have remissions that last for weeks or months. And patients need to be counseled on that and be aware of that.
Why do you think there's such variability? I mean, obviously we know that there's a variability in the severity of psoriasis. You could have mild, moderate, severe. plaque psoriasis, but in terms of like the remission, are you seeing more remission in the people who have like, say, plaque psoriasis, or it's just kind of very varied across the board?
Yeah, it's it's a great question. It's an area of research that's just starting to begin. Okay, there's some emerging data from Biologics that when people have newer onset disease, that when they're treated earlier, they respond better and maybe have better long-term responses. My own clinical experience with phototherapy fits that as well. I think that when they're earlier in the course of the disease, they tend to have longer remissions. But it's pretty unpredictable. The other thing is it can relate a lot to the environment where you are in the country. So where I am in Philadelphia, I have a number of patients who are like, they want to come up for phototherapy around springtime, and then they get clear, and then in the summer they're able to maintain clearance throughout the summer, and then things stay pretty good into the fall, and then towards the winter again they're coming back in, getting treated again, and they're ready for the next season again.
So we know when you're busy.
Yeah, right. Yeah, actually, it's fascinating. I just about a year ago I published a paper in JID Innovations with a team of scientists at AbbVie. We collaborated in this project. We actually showed that prescriptions for biologics spike in the spring. As does changing of biologics, spikes in the spring across all parts of the country. It doesn't matter if you're in Florida, where you are now, or in the Northeast or something like that, which is really fascinating. And there's an older literature out there suggesting that psoriasis is more likely to flare in the spring. We know Hippocrates used to say, if you want to treat disease, look at the seasonal effects, And we still don't have a good handle of why this is. I think we have enough hints to say, psoriasis is a somewhat seasonal disease. And it's probably not just the fact that they're getting more sunlight. There's probably something else going on that we don't fully understand.
I wonder if it has to do, because there's also like a cycle where with hair, like we think that people have like certain types of hair loss or hair regrowth in the spring versus other times of year. I wonder if it goes back to like evolution when you're thinking of like mating and stuff like that.
It's a fascinating thing. I mean, we know there's a whole new field of biology related to circadian rhythms and whatnot, and the impact that has on carcinogenesis and inflammation, things of that nature. And so maybe it's changing light, may have effect in this. I can only speculate, but it's a pretty interesting observation.
So you mentioned skin of color patients and how they're really compliant with their at-home therapy. Because they have darker skin and their melanin levels are different, what's the effectiveness of phototherapy? Is it varied from like a fair skin patient, skin type 1 to skin type 5, 6?
Yeah, so it's interesting. We previously had very limited data on this question in the United States, and so the White study really filled that gap. And what we saw is that patients do just as well at home or office, now what their skin type is. Although people of color, skin type 5, 6, these are people usually like Southeast Asians or African Americans, they tend to do better on objective measures, being clear, almost clear at home compared to the office. And some of that was related to better adherence rates. It's easier to do treatment at home than the office. But the other thing was that we found that the dosing in the office was often suboptimal for people with darker skin types. And we don't know exactly why that was. Some of it may be that if you're a phototherapy tech or nurse and you don't treat a lot of skin of color patients, it may feel a little nerve-wracking to give them 800 millijoules of UVB, the first dose, which is what the guidelines of care from AAD call for if you're a skin type 5, 6 patient. You're not going to burn a patient of that skin type with that dose. But we found a lot of the sites were still giving people lower doses, 500 millijoules to start. And it would take a good couple of weeks for that patient to get to what's called a minimal erythema dose, just starting to get to the therapeutic response rate. And they're then tanning, so it may preclude response even more. So it's really important. I encourage the listeners to look at the 2019 AAD, National Psoriasis Foundation's guidelines of care of how to dose narrowband phototherapy. Usually starting skin type 1, 2 people at 300 millijoules, skin type 3, 4 patients at 500 millijoules, skin type 5, 6 people at 800 millijoules, and then going up from there.
So it sounds like it's really like there's no downside to home therapy. And I know that the home therapy kind of was the biggest push probably came during the pandemic when people couldn't go into the centers for their phototherapy. And then we realized, okay, we need to do something about this.
Yeah, I mean,
But you all,
the biggest push from us, sorry to interrupt you, was really funding through something called the Patient-Centered Outcomes Research Institute, or PCORI. And they fund research that's geared to make patient care more patient-centered. And it's interesting, 'cause, being a researcher and dermatologist, this was not a high priority problem to solve for me, home phototherapy. But for patients, it sure was. All this work we did at the National Psoriasis Foundation and surveying patients and clinicians, we figured out actually patients really prioritize this. That's why we did this study. It was actually motivated by patients' surveys and interviews and involvement in the work that we do. And I think nowadays, really, it's the technological advances we have where the home phototherapy machines, have what's called dosimeters in them that make it really easy to use. I mean, basically, it's the same as the office. The machine gets a prescription from the doctor based on the patient's skin type, and the machine knows when the patient had a treatment. And the patient has to answer a question, well, did you have a burn? And if so, how long did it last? The same question we ask in the office. So the machine calculates what dose they need and doses the patient appropriately. So it's actually fairly easy to do now, and also I think safer for patients because it's harder for the patient to overdose themselves. The machine won't allow it, basically.
there might come a time when, insurance payers require that you have a home therapy machine before they allow you to go on a biologic.
Yeah, right. So I hope that will never happen. Cause I'm a big proponent of anything but step therapy. I think really you have to be patient centered and choose the right therapy for our patient. And so and I think really this is what's great about being a clinician, right? Because we're the ones who have to figure this out, right? So first, we assess the patient, we make a decision based on the type of psoriasis they have, the locations it has, their underlying health issues, whether or not we think they're able to manage the machine, whether or not they're appropriate for home. And in the study, those are the criteria. It was basically a clinical decision by the doctor. It wasn't like they had to have a PASI more than 10, and it was basically like the doctor thinks they're appropriate and the patient agrees and willing to be randomized, right? So we know clinicians can make good decisions about these things, and a lot of it's really about the clinical acumen about, is this patient's skin disease likely to respond based on the anatomical locations, and do I think this patient's going to be responsible and follow through?
Yeah, we always have to keep in mind that there's such variability, and it really isn't like, oh, you have to fail this before we give you this. That's not a way to practice medicine.
Right, absolutely. And I think it's really about us understanding the patient's perspective and helping them make good choices. As I always tell my patients, like I'll give them all the choices available. I won't let them make a choice I think is not safe for them and not appropriate for them, right? And so, someone was discussed earlier, if the disease is mainly their scalp and their nails and genitals, and they're like, well, I want something natural, I want phototherapy. I don't think that's appropriate for them. We're not going to do that. But certainly plenty of patients have disease mainly in their trunk and extremities and highly appropriate in that setting.
Do you recommend phototherapy for the scalp, or is having hair, like say if I had scalp psoriasis, would it be, would the hair block the light from penetrating?
Right. So in this case, I personally don't think home phototherapy is that great for scalp disease because, as you said, the hair blocks the UVB. But excimer laser can be very helpful in that setting. And certainly we do that a lot in our office. We'll offer excimer laser for patients with scalp psoriasis who aren't responding to topicals or don't want to do systemics or what have you. There are home modalities for that. We just haven't tested them ourselves. I personally don't use them, but I'm just not aware enough data that they can be used successfully at home for scalp disease, although I'm sure there's some device solutions out there.
So in terms of, I know you're a psoriasis specialist, but you are a dermatologist. In terms of other dermatological conditions, where do you see that phototherapy can be really beneficial?
What's really interesting, Hannah, is that we treat more people with eczema now than we ever had in the past. And a lot of that's because people are coming to the office now because we have advances in eczema. And these medications are amazing, but not perfect. So we have plenty of people on, say, dupilumab, doing well, but not well enough. And so they need phototherapy in addition to the biologic they're on. So we treat a lot of people with eczema, as well as people with chronic itch. Cutaneous T-cell lymphoma is another big one. And then adjunctive management for a variety of chronic inflammatory diseases that we deal with as dermatologists, lichen planus, pityriasis rubra-pilaris, things of that nature.
What's the thought process and mechanism behind the itch, the use of phototherapy for itch?
Yeah, that's a great question, and I don't have an answer for you on that. And it's really fascinating. So it does seem to help a variety of forms of pruritic disorders, ranging from classic prurigo nodularis, where they have lesions, to idiopathic pruritus, to uremic pruritus. So there must be some common pathway for the neuropathic connection that people are experiencing now, that sensation of itch, that ultraviolet light is able to turn off in some way, shape, or form. It certainly has neuromodulatory effects, but the exact precise way it's working, I'm not aware of.
Well, do you have anything else to add in terms of the future for phototherapy in dermatology? Are there any advancements in technology or methodology that you anticipate can enhance its effectiveness or patient convenience? Maybe AI will play a role in phototherapy in the future?
Right, yeah. Well, I think, phototherapy is a modality that we as dermatologists have relied upon, for over a century when it comes down to it. And as our practices get busier, our demands on our space get more pressing and what have you, I think being able to deliver phototherapy in a more patient-centered way gives us another real option, as well as the fact that we as dermatologists are not very well distributed geographically, right? So for rural communities, things of that nature. So being able to offer home devices, I think, is going to be a major advance in our field, especially if we get insurers and payers to make it easier for prescribers to prescribe these things. And then, I would say that we treat such a myriad of diseases in dermatology, and even though we have so many advances in treatments we're using, even our best therapies, don't clear 100% of patients. People lose response, what have you. And so we need many tools in our toolbox to solve these problems with our patients. And I personally find phototherapy is a very gratifying way to help patients. I get some of my most meaningful, epic, EMR messages back from patients when we clear them with ultraviolet phototherapy, because patients are very appreciative of the ability to solve their problem, sometimes without pharmaceutical management.
Mm-hmm. Yeah, I mean, everyone's always looking for a natural remedy, so
That's right.
this is probably the closest you can get.
Yep.
Do you have to be concerned at all with blistering more at home versus in office, or
Yeah. So it's interesting in our study with the light study, because patients got more treatments, that means they got higher doses because, of course, the dose goes up as you get more treatments. So patients at home had more episodes of what we call persistent erythema, redness lasting more than a day or two. But it wasn't clinically meaningful. When we asked patients a question about how itchy or burning or stinging their skin was, most of the time they said not at all, or only a little bit when they had an episode of persistent erythema. We had no patients stop home treatment because they had problems with burns or blistering or anything like that. So, the dose they're going to get with the home machines is basically similar to what we would give in the office. It would be pretty hard for a patient to have a medically significant blistering burn based on how the machines are designed. But again, it does depend on exactly what kind of machine you're using and what the safety precautions are in terms of how much of a dose the machine allows the patient to experience.
Well, it certainly sounds like a safe and effective method for treating psoriasis. So thank you, Dr. Gelfand, for joining us today. I really enjoyed this conversation, and I'm excited to see what the future holds.
Great to be with you.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.